Okay, great. Thank you for the opportunity and inviting me. And I apologize to the audience and to my panel about this minor technical issues. We also had what is it? We also had a daylight saving change here. So, okay, so without further ado, my talk today is going to be on primer for fetal MRI. And basically, as we progress, okay. Okay, I have no disclosures. So the topic for today, I'm going to give you a introduction into fetal MRI. And really, it's going to be more of a technical aspects and understand, you know, all the aspects such as biosafety for fetal MRI, image acquisition, and then go through some challenges in fetal MRI because you have to treat it differently to all the other MRI. So fetal MRI, as you know, allows for much more detailed imaging of the developing fetus in utero. Now, because the fetus is a moving target, we can't do anything with that. So all we can do is try and acquire it with the fast sequences that we have. And there are even challenges even with the fast sequences that we have due to fetal movement. Um, every aspect of the fetus can be evaluated using fetal MRI. The brain, the GI, the lungs, the pelvis, the abdomen. And typically, imaging is performed from the second trimester, second and third. We typically don't do it in the first trimester, and we can talk a little bit about that later. One thing I have to say, you never use contrast, gadolinium contrast, because gadolinium can get excreted into the amniotic fluid. The amniotic fluid gets swallowed by the fetus, and then it gets recirculated within the uterus and within the amniotic fluid and then the fetus, and then subsequent deposition. So it is a no-no. That's one thing we need to be aware of.
I'm sorry to
Now,
interrupt you.
yeah,
Can you like your slides are a little minimized on the screen? Can we make it a full screen or something?
let's see if we can do that. Keep slides updated. Let me just stop it and then let me see if I can change it over to.
Sorry about that.
No, it's okay. Let's try. Um, okay, I'll try this. I'll try screen one, and then we'll share. I don't know how to display settings.
Yeah,
Is that better?
yes. Thank you so much.
Yeah. Okay. So, right, let's go back to where we were. So biosafety. So as we all know, it's a very non-invasive exam. It's great because there's no ionization radiation. And from all the data that we have so far from years and years of experience from when it first started, it is relatively safe to the developing fetus. But despite this, there's still a recommendation that it is not recommended for the first trimester. Okay, so for the American College of Radiology, currently the recommendation is imaging after 18 weeks. We do image in our institution and elsewhere around US down the States. You can image down to 15 to 16 weeks gestational age. It's from that point of view, What limits you is not really the biosafety, but it's really the size of the fetus and how well you're going to see things. So, and also at that stage, the baby is so tiny, it has so much room to move. It is very, very hard to image a much uh, faster moving target. Okay. Now, as you know, ultrasound was the main imaging modality, and it still is. I would say ultrasound is the primary imaging modality. And what we should use MRI is really as a secondary uh, problem solving tool. Okay. I used to believe that MRI was like the best and it's obviously it's like higher image quality and whatnot. But no, I've changed my mind and both ultrasound and MRI are equal to each other. They are both complementary. Some some aspects of ultrasound um, is higher in terms of its imaging performance compared to MRI and vice versa. So so what can but we know that MRI is much more useful in both second and third trimester, especially in the third trimester, because by third trimester, the baby's bones have started ossifying, and so that can cause significant shadowing and shadow out areas of interest. So some of the things that you want to think about with ultrasound. So we have for the amniotic volume, that has prescribed prescribed uh, and and full on um, data on in terms of whether it's normal, high, or low. You can assess vascularity uh, in real time and in static image plus waveform. With ultrasound, we currently do not have any of that. And obviously, the real-time imaging where you can just watch the baby um, as you're scanning. MRI, on the other hand, as we know, has a higher tissue contrast. It can confirm or add additional findings, and it does significantly add value for intracranial issues. It has a higher sort of, it can add more value and percentage in terms of lesion detection for intracranial anomalies. Um, but saying that on that point, the ultrasound with a 3D, with now 3D imaging, uh, it can really has like higher resolution in terms of spinal lesions. I'll tell you that from a real life experience. Okay, um, and as I've sort of just to go a bit further, MRI also has a larger field of view. You can see the maternal information, if there's any issues going on, or if there's any sort of unknown entities that the mom might have that is then, that has an impact on the fetus. The multiplanar capability is also a significant strength, because especially with sagittal brain imaging, it is very, very challenging to get that sagittal posterior fossa view by ultrasound. Um, and we've already mentioned about the strength of ultrasound in terms of its first line and screening um, performance, and the vascular and Doppler assessment, which MRI cannot currently do. What are the limitations of fetal MRI? There are a number which you need to be aware of if you start imaging the fetus. So there is this reduced signal to noise ratio. The smaller the baby, that's going to be more impactful. Also, partial volume effect. That's also another impact, especially prior to the 18-week gestational age. And again, that's all to do with that signal to noise and the size of the fetus, especially with fetuses that have like IUGR, so intrauterine growth retardation, so much smaller than what they're meant to be. That's another issue. Maternal factors are big consideration, especially now with the obesity pandemic. So we need to be aware that there is a weight and a bore size limit for moms, which that cannot exceed the table recommendation. Um, Moms have a significant amount of claustrophobia, and we can try and counter that with distraction methods such as music or video playing inside the scanner. Other problem solving techniques that you could use, you could either put them in feet first versus the head first. If you can get them feet in, maybe they can stick their head outside the bore, and they're not going to be so claustrophobic. If they have any implanted ferromagnetic device, that's a sort of generalized no for all MRIs, whether it's fetal or anything else, and then limitation by fetal movement. The other thing that you also need to be aware of is again, which is the actual not just the size of the mom, but if they have high BMI, uh, that's a lot of like tissue for the radio frequency waves to go through. So that really degrades the image quality really significantly, not just for MRI but for ultrasound. So that can be really challenging. Some we have moms of like greater than 300 pounds. So again, that's going to be very challenging. And in these moms, especially with the diabetic mothers with the high BMIs, they have a high risk of fetal anomalies because of that. Now, how can we improve this with these limitations? I put this in yellow because unlike any other MRIs where you can tell the technologist to scan, um, you really need to supervise the fetal MRI by the radiologist, either at the scanner or at your PACS while watching it in real time, and the tech is scanning. You really need to do this. I do this. We do this as a group for all our fetal MRI because you don't know what you're going to get. That's one thing, not just the motion, but if you find additional findings as the images are being acquired, you can add sequences because once they're off the table, then that's it. They're not going to go back on. You only have basically a one shot time. Even if that one shot is like 45 minutes, once the mom is on the table, that's all you've got. A little bit like functional MRI, really. The data, once you have that data, you can't change that data. Um, Next, I would say appropriate patient positioning. The best position for the mom would be on her back. And here, the best is really just one channel or sort of one um, coil on her. If the mom is much bigger, then you can use two coils, but obviously you're going to have a gap, so you can overlap it. So that's also another option. Um, the mother needs to be in a very comfortable position. I know that sounds very obvious, but if they're not comfortable, they're going to be moving. Even though small motion can really affect your imaging. Um, this a lot of moms refer, especially the bigger moms and also third trimester, when they're very uncomfortable lying on their back because that pregnant uterus is on their IVC. So they typically prefer to lie on their side. Now, this basically illustrates why it's not good because here's the mom's spine. They're more comfortable. Yes, they're not moving. But then what happens to the coil? The coil is here placed. So we're not at the isocenter. We're not, and the fetus is off the magnet isocenter. So you're going to get more image degradation and artifact. But if that's the way it has to be, then it has to be this way. If that's the only position. But really, um, I would suggest your technologist or yourself talk to the mom and try and get them on their back, and that's the best position. Um, And obviously, coil selection, you want the highest coil channel. 32 is the best, but obviously you have to use whatever you have. Obviously, as you go lower, sort of less coil, then you have less signal from that point of view. Next, I'm going to talk a little bit about 1.5 versus 3T. So we obviously have more 1.5 Teslas. We have a couple of 3Ts. The 3Ts, you think, okay, it's great. It's not great for everything. Okay, there are caveats to that. The 3T will provide increased signal to noise ratio, that better spatial resolution, and it is also very, very good for CNS indication. So fetal CNS indication gives you that high resolution for the fetal brain. However, the negative side is that when you have a mom with polyhydramnios, and you'll know that really by ultrasound, if the amniotic fluid has been accumulating more, then really you don't want the mom on the 3T. And I'll show you a reason why that is, because it causes a significant artifact because of the polyhydramnios. And then what you're going to get out is absolutely not very good information, even garbage really. And so if they end up being on a 3T and they have poly, I would recommend that you transfer them off. It's going to take more time, but I would recommend taking them off the 3T and transferring to a 1.5T. Now, the other thing with imaging on a 3T is you get that high resolution, but things take longer to image, especially the T1. So the T1 sequence is much longer on a 3T versus a 1.5. So that increased duration of sequence can also that increased time, that time penalty is then going to, they're going to have like mom or fetal movement, right? So the 1.5 is our workhorse, and it's still good. It's still excellent. It's great for moms with polyhydramnios. Oops, go back. There's less time for the sequences. There's still good spatial resolution. And here's an example here of a 30-weeker versus a 24-weeker here. And then there's more availability on the 1.5. So in terms of sort of workflow scheduling, obviously there is a little bit of less SNR, but overall it's not a big deal. Oops, wrong. So what is the problem with that poly on the 3T? So it causes this banding artifact, and this is it. Okay, this is what you're going to get on a with poly on a 1.5. You get much more. This is just flow artifact, the low T2 signal versus this, and it can go much more into the area of interest. And here you also get this banding reverberation all on the T1 also. This is an example of where that banding extends through the area of interest. Here you go. So really, you're not going to be able to say much really on the sagittal, but you can say grossly, but that's not the value. And it's really the edges of the field of view and at the tissue interfaces that this banding occurs. And what is this artifact? Well, no one knows. There's sort of two theories. The main theory being it's the dielectric effect. So the electromagnetic field, the EMF in the MRI involves the magnet plus the electric field. Those changes in the currents between the interaction between the soft tissue and the electric component of the MF leads to this artifact. And there's also areas of what's called what it's not just that band. There's areas of regional brightening, i.e. the signal from the bright fluid. It gets way too bright and it's hard to window it down. There's also going to be signal loss. And the other theory is it could be this RF coil effect where there's not enough RF penetration. But either way, you're going to get problems. Now, just running a bit we're just going to run through these slides, but these are the whole, like, you can go through all the tons of CNS indication, CNS spine and head and neck, and here's just a sample of them: hydrocephalus anomalies, um, 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 and spinal anomalies, neural tube defects, virtual body anomalies, sacral teratomas, neck masses, airway issues, and here's just an example of ancephaly here in a uh, twin uh, fetal MRI. Here you can quite clearly see on this sagittal image here, there's micrognathia. That facial profile is abnormal. This was a case of question of Pierre-Robin sequence. Um, anything you can see on you can see lymphatic malformation and a whole host of body indication also. So lungs, we use it for practically everything. A lot of like CPAN, sequestration, congenital diaphragmatic hernia. That's a big we get a lot of referrals for that. You can get surprises where they come in for this like CPAM or and it turns out to be a teratoma. um, Abdominal indications, bowel obstructions, omphalocele, cystic lesions. Is it a cyst? Is it a in utero cyst, or is it lymphatic malformation? Um, Renal indication. Uh, Here's an example. Basically, this is the baby spine. This is one kidney is the other kidney, but there's basically bilateral renal cyst here. Here's a cyst. Here's the kidney. Another cyst here. Here's the anterior abdomen, bowel, and liver. So bladder obstruction, multicystic kidney disease, unilateral kidneys, and we can even see anal rectal malformations. So here's an example from our institution of an omphalocele. You can quite clearly see the herniation of that liver really externally, and then you have to evaluate what else is being herniated. Here's a urinary tract obstruction. You can see really this growth, thickened bladder here, really abnormal morphology also, and the ascites, free fluid in the abdomen, could be could be urine uh, urine sort of peritoneal uh, uh, there. Um, and then here's just going through um, our sort of so this is what I also wanted to tell you. So before we had a fetal surgeon, we we had a more generic MRI for the fetus. But now working with our fetal surgeon and other centers, we have very specific indications. So these are examples. So you need to have more neurospecific protocols and also body-specific protocols. And it's ordered that way, okay? So it's either ordered as a fetal neuro or fetal body. The main we have a spina bifida unit, so we get a lot of Chiari 2 questions, but any other sort of brain malformations and come to our institution, we get lots of ventriculomegaly, cleft lip, palate, cervical masses. So the top two are are the um, are the sort of more common indication, and then just going through the body specific, we have specific indication for congenital diaphragmatic hernia, um, bladder outlet, and then we segment it out depending on the skeletal dysplasia. You want to also take out separately in terms of if you have they're not common in terms of the fetal indication, but they do need more specific sequences, really looking at the limbs and also the spine, things like that. And then we have the bowel obstruction. So the bladder and bowel obstruction have more sort of more the urogram type T2 weighted sequence compared to the other sequences. And we have also a separate twin indication, especially for twin transfusion. some of the sequences that we have really for the Lurie MMC is the T2, T1, but you also want the sort of the DWI, and we have cine loops. Um, and then we'll talk about it a little bit further. Some of these standard sequences. So the main standard sequences for fetal MRIs that heavily T2 weighted sequences. So there's two varieties. There's the haste and there's the Truffy. So there's either haste, uh, which has half Fourier acquisition single shot T turbo spin echo. You can also have a variant of that, which is a steady state free precession SSFP, and the Truffy, which is also another steady state free precession. Either one, depending on your vendor. And then we have one T1 weighted imaging. You also want to include DWI, not just for ischemia, but DWI is also indicated for normal tissues, and I'll give you an example of that later. And then you want an EPI sequence, really looking for blood products. So this is the difference. This is what you get with a haste intracranially. You can see that, and this is a 21 weeker for a Truffy. Okay. So the T2 is really the workhorse for fetal MRI. It has excellent visualization for the fetal anatomy, especially intracranially. It allows optimization for tissue contrast, uh, and due to and it gives that contrast, especially with the amniotic fluid uh, versus the um, versus the fetus, and then intra uh, fetal, you can find the fluid-filled cavities such as the bladder, stomach, and gallbladder, which you must find in every case. Just like with ultrasound, you get that anatomic detail with the lungs, placenta, and also the fetal profile. Um, and these are really the two main sequences, the SSFP or the True Fist and the haste. What is the difference between the two? And we'll run through a little bit about that. So the SSFP has a higher SNR compared to the haste, but the haste still has good resolution and T2 contrast. The problem with the True Fist, it actually causes a large sound, actually in the MRI scanner, which some of the moms really don't like. And it just comes across in terms of, if the mom's unhappy, the baby can be unhappy. And, this is anecdotal evidence, but, I believe there is some sort of, maternal fetal sort of connection. If the mom's unhappy, the baby can be unhappy, and the baby comes out very unhappy by just moving around a lot. It does have a higher temporal resolution. It's faster, so faster SSFP compared to the haste. And also one of its true value is you can acquire repeated acquisition of the balanced SSFP in the same anatomical location over time, and then you can um, combine it all together to give you that real-time imaging. Why do we care about that real-time imaging, the real-time cine imaging? So that's excellent for the limb movement during a Chiari assessment. We typically want to assess the sort of the lower extremities, looking at the sort of ankle, knee, and hip joints. If there's motion in the fetus in utero, because that has the sort of prognostic value postnatally. And another entity called arthrogryposis, where there is lack of movement, really the limbs, both the upper and lower in babies with arthrogryposis, that can affect either just unilateral one limb or can affect all limbs. And in terms of the haste, it is more excellent looking for the CNS sort of different layers of the intracranially. So you have that external sort of cerebral cortex, you have that dark signal from the germinal matrix, and then you have the intermediate zones, the subplate, and then you have this intermediate zone. And here's just examples of that. And then this is what I'm talking about, the sort of the general localizers to see the lay of the land, see where the location of the placenta is. And then I also double check any sort of any issues with mom. And then you can give a gross overview really as to where the placental margin is compared to the internal os. Obviously, in the second trimester, that has a time to move. It can go down. If it's low, even in the second trimester, it can go up. So it's there's a lot of value in that. So the SSFP, as I said, it gives you that larger field of view. It's a faster acquisition, fewer motion artifacts, and it's actually very good for axonal migration, especially in that third trimester. Is best depicted with the SSFC. In terms of the haste, it is much faster. And the other thing, and if you start doing fetal MRI, if the mom stays on the scanner, so 45 minutes to an hour plus, they start wanting to come off, not just because they're uncomfortable, they start feeling very hot. That heat deposition also increases by a factor of 3 with using the haste, but also the 3T has a higher and faster SARS deposition compared to 1.5 also. That's also another factor because they're just going to want to tap out and come out. Um, T1 imaging. So the T1 we use um, now we only have like 1 or 2 sequences for that. Why is it of value? Just like with all postnatal imaging, T1 is good for looking at fat, calcification, subacute hemorrhage, or any other proteinaceous structure. Um, they do need to breath hold, and it's typically, 30 seconds to a minute. It doesn't sound that much of a big deal when you say it in that length, but you'd be surprised how few uh, moms can do that really. Um, and um, so that that can turn out not well if the mom cannot hold their breath. Um, and you can also do a fat suppressed T1 that allows more for specific detection of the of fat, intracranial fat, or intra or body fat. Um, and there are normal structures that come out T1 bright. Typically by 20 weeks gestational age, the thyroid and pituitary gland will be T1 bright. I used to think that you can't really see that, but once you start looking for it, it's amazing what you'll see. And you've got to be aware that the liver is normally T1 bright due to the high iron content, and that can help with congenital diaphragmatic cases. So here's an example. This is what's normal T1, and this is actually T1. You can see that intracranial T1 intrinsic signal here, and this is the corresponding EPI, basically showing intracranial hemorrhage bilaterally here. Okay, so it's pretty confirmatory. And here liver T1 bright, you can see. So for congenital diaphragmatic hernia, this is an obvious case of liver up. So, right, so that's one of the sort of things that we want to talk about, discuss in terms of congenital diaphragmatic hernia cases. Is the liver up or down? Because that has an implication in terms of prognosis. It's also useful for urodigestive fistula, and I'll show you an image of that here. So meconium. So meconium in bowel is T1 bright. This is normal. You want to see that. You want to see not just the caliber, the location of the bowel of the large bowel loops. Typically, it's in the large bowel, and also can be you can sometimes see meconium in the distal small bowel loops. But you want to see the meconium go to the extend to the anal margin. So the meconium column to the anal column here's the sagittal coronal. Look for the position and colon. Now here's the abnormal case really of a cloacal anomaly. You can see here's the bladder. So sagittal anterior bladder. Here's the uh, is actually a very dilated vagina and uterus up here. Here's the meconium. So here's another sort of T2, and you see that there's T2, T1 bright signal here, meconium delineating the bowel, and here's already a bowel loop. So So that can help with cloacal malformations, anal rectal malformations also. DWI. So as I said before, DWI can detect ischemic lesions. Ischemic lesions. Sorry, let me just get some water. Ischemic lesions in the brain parenchyma. Um, this was Here's a case of hemorrhage. Here you can see the diffusion restricting here, right? And then you can see that intrinsic T1. So it's actually more of a subacute hemorrhage, a sort of subacute. So this was hemorrhage plus ischemia, so marginal ischemia. And this is more parenchymal. Now, the normal diffusion restriction occurs in the fetal kidneys, and here they are. They're not ischemic. This is normal. Why does it occur? Fetal kidneys normally restrict due to high cellularity. So when you're actually looking for cases of the is there just one kidney or are there both kidneys missing, then the DWI is uh, is excellent. You can do it in different planes: axial, coronal, sagittal. And here's really um, a, a case of Potter sequence where you can see quite severe anhydramnios. You can see barely any fluid here. Okay, on the axial T2 weighted, heavily T2 weighted. This is more of a heavily T2 weighted where we do a more of a urogram image. There is no kidney, and and there's no bladder really. You also see that there's no fluid filled bladder here. You can confirm that by also doing a multiplanar DWI sequence. Um, Here's an example of EPI. So the EPI, just like postnatally, is a very fast sequence, and motion is not a problem, but you can get what the susceptibility induced distortions, and that is further increased at 3T. So, and then this is it. This is that 3T susceptibility induced distortions. You can get distortions actually from quite surprisingly, this is what I learned early on. So, if fecal material has sort of can have like higher proteinaceous and iron contents, especially if the mom is taking any sort of iron tablets or anything. So you're going to get you can get, because bowel is going to be surrounding the pregnant uh, uterus, right? So you can get susceptibility resultant from the mom's bowel loops also. So especially in the third trimester, when the head becomes more cephalic presentation, right? So that can affect imaging from that point of view. Um, Motion in fetus with hemorrhage. So this is what happens. Okay, it's really bad. So this was the hemorrhage, and this is the the imaging on ultrasound. You can see the lesion, but you can't really tell by ultrasound what it is. So this baby came on to have the MRI. And with the MRI, I was much more confident that this was an intracranial hemorrhage. It's not a mass, right? Okay. And the EPI also helped significantly confirming. And we can also see that it was subacute. Okay, and as it's mentioned, stool, so air and iron content in the stool in the mom uh, forms susceptibility. This is right next to, here it is, here's that susceptibility distortion. And again here, there. So especially in the third trimester, when there's and even in the second trimester when the head is the presentation component down in the pelvis. EPI is also excellent for looking at those skeletal anomalies that I mentioned earlier. So here's the sagittal with the sagittal spine. So the EPI is great for bones. It still doesn't have that fine bone detail that you can get by ultrasound. So here's the scoli um, by ultrasound. You can really quite clearly see here is the same patient on uh, coronal EPI. Sometimes with the ultrasound, especially the 3D, you can get more of a sense of what the virtual body shape is. We're not at that level yet with MRI, and actually to get like good EPI sequences, it's not straightforward by MRI. Still not there yet. But you get a good overview of the entire spine, the cervical, thoracic, lumbar, and sacrum, and any sort of dis dysgenesis or abnormal calvarial shape, anything else that the baby might have. And just to round off, a few more examples really of this talk, and I'll leave some time for questions. Here you can just showing you examples of the excellent sort of details that you can get, sort of bilateral cleft lip and palate. Here's anterior, here's the eye, and this is what I'm talking about. Also, you can get a sense that the head shape is not normal. Here, the cleft lip extends into the palate. You can see the T2 fluid signal in the mouth. Here's the tongue, and here's the nasal cavity. You can see there's a wide gap, and this is what normal looks like. Okay, and here it is. This is on axial imaging. This is like the complete loss of the palate. Here's all that T2 signal, bright signal that's not meant to be there. And again, this is what it looks like on the satchel. This is what normal looks like, okay? And here, where is that? Where is that shelf? It's not, this is the tongue. The profile is abnormal too. And this is just an example really of like how ultrasound and MRI can work together really nicely. So this is a case here on ultrasound, both kidneys are echogenic and enlarged. The corticomedullary, they have, we have measurements that we can use by ultrasound. We don't really have like prescribed measurements on what's enlarged. We don't have all the sort of normative reference measurements by MRI as we do with ultrasound. So I think that's why the two go really nice hand in hand. You can quite clearly see there is no bladder, and you get a finer detail look on the cortical medullary differentiation is decreased by ultrasound. A few sort of cortical cysts, and here you can see all these like more cystic cortical uh, lesions. And the question was this multicystic versus calyceal dilatation? And on axial imaging, you can see that it's there. And this is another case. Sorry, this is the same case. Here's the DWI. There is no positive DWI on this case, basically, which means that even though the parenchyma is present, it's unlikely to be functional. It's like there is no use, right? No functional. So that's what I just went to show you. And then really, in terms of what we want to think about in terms of the echogenic fetal kidneys, here's a whole host of um, of differentials, intrinsic abnormality, overgrowth abnormality, again, where you want to look at the entire fetus, aneuploidy, i.e., sort of the trisomies, the main suspects are T21, 13, and 18. Meckel-Gruber, that goes on a lot of list of differentials, even for body and intracranial. I haven't yet come across a real life case yet. But yeah, it's on a large differential. And to that, I'm going to end my talk and leave some time for questions.
Thank you, Jessie. That was such an amazing and comprehensive review of how to approach a fetal MR and how to acquire it, and also such amazing examples. I was particularly quite excited about the role of DWI and looking at the kidneys. Yeah, something that I haven't done before. So thank you. Just going to go through some of the questions. So, what additional sequences are to be taken for the body imaging protocol?
Really for especially renal lesions and and then I've now started using it for is this a cyst? Is it a lymphatic malformation? You, I love the heavily T2 weighted urograms, just like you use for postnatal urograms, because that will help you find, especially when and especially when all these like collateral malformations, and so you want to use it's T2, so it's fluid filled, but is there a connection between the T1, so i.e. meconium bowel? Because what can happen is you can have a fistula, right? You can actually detect in utero fistulation between the either between the bladder and the bowel, or between the sort of the bowel and even the uterus. And what's going to happen is that meconium signal gets washed out. It's not that bright T1 bright, because fluid and meconium starts mixing, and you get this like this, as I said, like a washed out, like very, it's T1 bright, but it's not as bright as you expect it. And so gives the surgeon a bit of warning that there could be a fistula between it before the baby comes out. So it's not going to be, you're not going to say, oh yes, you're not going to see that fistula, but that's going to give you a hint that there is going to be something, that there could potentially be a connection. So the baby's going to need like fistulogram and high colostomy pressure colostogram postnatally. So you can start thinking the team, you know, and fetal imaging, I would say, need to be a team effort. We're not. It's I work closely with my maternal fetal medicine, even though I also read fetal ultrasound. There are days when I read MRI and it's the maternal fetal medicine person who's reading the ultrasound, we work closely hand in hand so that there is more of a combined approach, collaborative approach. Like, especially like the one example, there's a case where the baby came in for question of is this a CDH, congenital diaphragmatic hernia, or is this a lung lesion? But then and then the fetal echocardiologist was also involved because there was like significant compression of the heart, so they were assessing. And the mass was so big, like they couldn't the cardiac imager couldn't see lesion. Anyway, MRI in that case, I used T1 for the body indication, and I found fat in the lesion, and that to me, that was a no-brainer. That's a teratoma. That was a teratoma. And that that was like, that was surprising to everyone, not just the parents or the clinicians involved. And then you had to like change everything, change the counseling approach, because this wasn't a case of, oh, this is for surgery. This is really like devastating news.
I have a question of my own as a follow-up to that. So a
Hmm.
couple of months back, we had this fetus, I'm sorry, this mother with on the ultrasound, they found a mass in the abdomen, but they couldn't quite understand the organ of origin. So we went ahead and
Hmm.
did the MR. And
Hmm.
on the MR, actually, it became quite difficult to understand whether it was liver in origin or was it retroperitoneal, in the sense that not exactly retroperitoneal, I would say, somewhere in the vicinity of the posterior margin of the kidney, and a huge mass. Like it was, I think, at least about 3 centimeters or so, like really huge. So
Hmm.
the maternal fetal team were a little insistent that, is this a hepatoblastoma, or the other differential was a neuroblastoma if it isn't from the liver? Because then similar, how do we counsel the parent post delivery? And then once the baby was born, it was very clearly not from the liver. It was a neuroblastoma. But I wonder, like we did all the T2 sequences, we tried our best, but it just
Did
was,
you did
yeah,
you see the adrenal glands on ultrasound?
no, no.
Well, yeah, so that you have to take that. That's a red flag. You have to find the adrenal glands, right?
Okay.
That
Because we couldn't see bilaterally, we were not sure, what is it compressed by the mass, like what's happening. I think it was just a little hard to sort of label that, but yeah, I guess that would have been a
yeah,
big.
you have to check off all the AIUM like uh prescribed like organs that has to be found. If you don't, then okay, is it not seen or is it because like because that's the classic, right? Is it a neuroblastoma versus adrenal hemorrhage? And you can only know like postnatally. So that I would say those two would be on the table because you definitely have to look for the adrenal glands, especially if yeah. And we look for adrenal glands also. That's why that's why I say now that the ultrasound and the MRI, you have to do it hand in hand, or you work closely with the MFM. There's a lot of there's very few fetal images that do ultrasound and MRI, and I'll actually scan them myself sometimes as well. I mean,
Okay.
my tech is very good. She's a dedicated fetal sonographer, um, and she's got years of experience. But sometimes I'll like do it. My MFM colleague, he scans every single one of his. That he's old school, but um, one to keep up his skills, and I think also to make sure that he gets everything. It's like he just puts it on. So so I would say you have to look at the ultrasound. The two has to be, especially in these complex cases. Yeah.
Got it. Thank you. So the next question is, can we see the fetal diaphragm on ultrasound and MR?
Yes. Yeah. We use the diaphragm. We take the diaphragm, like that's an AIUM image that has to be acquired, and then you can see the diaphragm. Uh, on the same like with ultrasound, it's the sagittal plane, sagittal coronal, but you see that nice like curve to the um to the liver. So you don't necessarily, you might see a very thin line, but you don't necessarily see it. If you don't see the diaphragm, then typically, things herniate into the chest.
Um, uh, we have another question from the same person who's asking how to differentiate congenital diaphragmatic hernia and lung hypoplasia.
Well, congenital diaphragmatic hernia, you're going to have like a lot of organs in the in the chest, right? So if there's a diaphragm intact, you're just going to get an eventration, i.e., it just like the liver goes up, but there's you're not going to have bowel contents going up there. So I've got one case of liver eventration that I reported a couple of weeks ago. It just it looks. I mean, I would say like fetal imaging is very much like postnatal imaging. It looks like what it does postnatally. So the bowel was not up there at all. Kidneys were down. It's just like the liver humping up a bit, and it wasn't as high up. Sometimes like the liver. So with congenital diaphragmatic hernia, it's not just the liver. You always have to see where the um, stomach is, because that's worse prognosis. Also, if the stomach is up, especially if it's and the heart is like massively displaced. In the eventration, that the heart wasn't displaced; it was still sort of paramidline. Um, so you have those differences, right?
Um, okay. Sorry, just give me one sec. Is it possible to assess appropriateness of gestational age in fetal MR?
What do you mean appropriateness of gestational age?
I don't know. There's no follow-up question to that. I think we'll just, yeah, leave that at.
Well, I mean, I say that for like the CNS cerebral gyration. So if certain gyri are present or not present, then, then that can help you. Is this lissencephaly, or is this like, uh, or is this like, immature stuff like that. And in terms of the gyri, so that's an additional point. You can have also too much gyri too, right? If the cortex, the rest of the cortex is smooth, but you have an area of irregularity, that's polymicrogyria until proven otherwise. Things like that. So yes, you can, but you do it as a sort of brief overview. There's no like this is the exact gestation, like the gestational age is obviously determined either by, well, there's two methods that the OB-GYN use, right? I don't know what they, I'm sure it's more universal. It's either the last menstrual period according to mom or the expected date. But the LMP is not that accurate, really.
I think I think the follow-up to that is that I think for the fetal growth assessment, in terms of correlation between LMP and the growth of the fetus for gestational age.
No, I'm not aware. That's an ultrasound parameter, I would say. I would use, I mean, ultrasound has years and years of standardized and accepted reference, and they've had thousands and thousands that's been referenced versus MRI. So I typically rely on the ultrasound parameters, right? It's the abdominal girth circumference for the fetus, and whether it's in uterine growth restriction, that's typically like less than 10% um, ultrasound parameter. You can get a sense even before I see the ultrasound report, if the baby is smaller than it should be. The more you do of fetal imaging, you go, oh yeah, that's about a 20 weeker. Yeah, that looks about right. Or a 30 weeker. But if they look smaller than a 26 weeker, I think no, that doesn't look right. I wouldn't be surprised if this baby's got IUGR. And if it then I can give a guess, but I'm not going to be. I would use the ultrasound as the sort of final arbitrator.
What is the B value used in DWI?
I think we use. I have to go back. Maybe 600.
Um, okay, so the next question is, so if there is no restriction of kidneys with echogenic kidneys on ultrasound, can we confidently say it's multicystic or ARPKD?
Um, no, I think it's the differential. Well, if if you have, I would say if you have very large, like variable shape renal cysts, that would sway me more towards multicystic versus the ARPD. I feel like they're more smaller cyst, diffuse more smaller.
Um, is there any other role?
And sorry, typically AR is bilateral, right? AR
Yeah.
is bilateral. Multicystic can be more unilateral than bilateral. So it's all these little.
Is there any other role of DWI apart from detecting intracranial bleed and and for the kidneys?
Teratomas.
Mhm.
It's either intracranial or body teratoma. They're gonna you you'll see a tiny. There'll be in that chest teratoma. There was one or two areas that was restricting, and that
Uh-huh.
was restricting also because of the hemorrhage too. The teratoma was enormous, but there was areas of hemorrhage in there.
Do you do fetal MR for placenta accreta spectrum?
No, we don't. We do not do placental imaging uh, at Lurie. Other centers, I know of one other center that does it, um, but um, but we don't do it. As I understand it, you need different sequences for that.
Okay.
And we do. I just saw a question about tracheoesophageal fistula. Yeah, we do. We
Mm.
image those for that. I try. So that is one you definitely have to be at the scanner or with your tech. I'm trying to chase that view of the esophagus, and sometimes you can get it just by pure chance. The sagittal and the coronal, like, and then I try and get the tech to like just image that chest. But sometimes you need the whole body to get more of the more SNR.
Okay. But but do you like end up confidently calling a TE fistula prenatally, or is it still something that you will say, we'll have to do it, postnatal evaluation eventually?
No, yeah, postnatal. I mean, I've only done a handful of these cases, but